Cassie from Vetfolio and the host of Vet2Vet. For this episode, we're discussing a couple of different dermatology cases with the derm vet herself, Dr. Ashley Bourgeois. She'll be sharing with us some great advice for those of us in general practice and helping us kind of put on our dermatology hats, if you will. And Dr. Bourgeois, I feel like I get to put on that dermatology hat very often practicing here in Florida. So I'm excited to really dive into these cases with you today. Thank you so much for joining me.
Oh, thank you so much for having me. Dermatology is really universal specialty, right? That's why I love it so much. There are certain areas, and Florida is definitely going to be one of them, that are really, really heavy on dermatology and allergic dermatitis. But I promise you, I practice in Portland, Oregon, and we see allergic dermatitis all day, every day. So this is one of my passions, is really just teaching general practitioners how to be amazing dermatologists, because I truly believe you can do wonderful dermatology in general practice. So I'm very excited to go through these cases with you.
Absolutely. Absolutely. And I keep finding that the more and more people I talk to, that Florida does not have the monopoly on dermatology cases, even though it feels like it sometimes. And you're right. We all have to treat these cases. So let's go ahead. We'll get straight into it. Our first case is Chief. He's a 4-year-old male neutered golden retriever who has a history of seasonal spring facial, forelimb, and pedal pruritus. And he's responded to symptomatic care in the past, which has consisted of maybe short courses of steroids and antibiotics. But this year, things seem to look a little bit different. And he's continuing to be symptomatic into the summer and has had also a couple of ear infections. Ashley, what are some of your first considerations with this case?
Yeah, very typical case that we get referred to us. At one point had a certain season that seemed to bother them, and now we've moved into other seasons. So when I have a case with that history, I start to think of one of two things. Either something new has come along besides atopic dermatitis, right? We can have other things like food allergy come along, or maybe something that's not an allergy at all. Or we truly are just an atopic dog that has started becoming worse. And we know that this is a progressive disease and that can happen. So no matter what, we want to make sure the pet is comfortable. So I'm going to reach for some symptomatic control, whether that's Apoquel or Cytopoint, to make sure that they are feeling good as we start to dive into what the cause of the allergic pruritus is. Now, I like easy wins in dermatology. So one of the first things that I'm going to make sure is that dog is on a good isoxazoline, because we want to control ectoparasites. Though we don't want to think about fleas and other little things that we can't see that may be affecting our environment. It is something that can cause allergic pruritus. It can cause them to be uncomfortable, and it's easy for us to control if we can get that client to commit to actually having them on something like a good isoxazoline. We also have to reach for our slides and get cytology, because that's the other thing we'll see is infections like yeast or bacteria that maybe some sort of symptomatic control used to work before, and now it's not working as well. So we always diagnose infection based on what's under the slide, not based on how they look. I know it's super simple to smell corn chips and think, it's just going to be yeast, or to see scaling and think it's going to be pyoderma. But I have had case after case fool me, even as a specialist, finding something under the microscope that I do not suspect to see. So I'm going to go for those easy wins like ectoparasite control, make sure they're on a symptomatic control that keeps them comfortable as we dive deeper into that case, and get my microscope slide out and look under the microscope so I can identify things like yeast or bacteria that might be complicating things.
So thinking about a dog like Chief, who obviously things have progressed at this point, but up until this point where he's been managed symptomatically, how do you feel about that type of management in a case like his before all of these changes happened?
Yeah, I mean, when you are seeing a dog with allergic dermatitis for the first time on their initial visit, or even if you have a dog who just 1 or 2 times a year has a flare, I don't think there's anything wrong with kind of focusing on those 3 main steps. And we can see that depicted really nicely on this little graphic here. Symptomatic treatment to stop the pruritus. So we're going to use Apoquel or Cytopoint to help get that pet comfort from the allergic pruritus. We're going to have them on really good isoxazoline ectoparasite control so that we can rule out parasites. We want those easy wins, of course, and always doing cytology and treating skin infections. And you may repeat this, once or twice a year, depending on how that case is presenting to you. And that's completely appropriate for a first-time dog with allergic dermatitis or for 1 or 2 flares a year.
Let's circle back around to Chief real quick and ask, how would you approach Chief's diagnostic workup specifically?
Yeah, and Chief is truly a case that I have seen. So I can definitely speak personally to this case. And it is a common one that we see. We're going to skin scrape because we do want, if we find something like a mite, right, and that could cause us to all of a sudden be itchy all the time, despite the season, we're going to treat that probably before we approach much more of a workup. But there was no mites found on skin scraping, cytology, and there was infection found. He already was on a good isoxazoline. So I've already kind of hit my top 3, right? Like, we're going to figure out a symptomatic control, but we're going to make sure the ectoparasite control is on point. We're going to make sure that we're treating infection appropriately. So when we have a case like Chief that needs a more comprehensive workup, because we are having flares, 3 times or more a year, then we want to extend, as we see in this graphic here, and start thinking about things like food allergy and do a diet trial, or confirming they have atopic dermatitis and figuring out that long-term management, such as Apoquel or Cytopoint for allergic pruritus. And this is when you could consider referring to a board-certified veterinary dermatologist for allergy testing and immunotherapy. Chief was really interesting case. We actually did end up doing a diet trial because he was a case that all of a sudden he's showing us otitis. He hadn't really shown that before. He's showing worsening severity of his symptoms into other seasons. And so it's definitely appropriate to do a diet trial in a case like this because we can see dogs develop food allergy, even if they didn't show us that before. Now, in the beginning of something like a case like Chief, I also like to make sure, again, they're comfortable. So while we're addressing infection and that's under control, I really like Apoquel for the use of controlling the allergic pruritus because it has a really great way to start and stop it, right? It's an oral tablet. So we can start it at the beginning of something like a diet trial in a 4-year-old dog. While we're treating infection, he deserves to be comfortable. We get through those 8 weeks of a diet trial, and then I can try to stop it. And then we'll know very, very quickly when we stop that Apoquel, if all of a sudden the allergic pruritus doesn't really come back, fabulous. Well, then maybe we truly have a food allergic dog. If it does come back, then we can really go into our workup of atopic dermatitis. Well, Chief kind of did both. So we were able to stop the Apoquel and he was much, much better, but there was still some of that allergic pruritus coming back. And so we had confirmation that Chief actually was a food allergic dog in an atopic dog. So he ended up going on being allergy tested, going on allergen specific immunotherapy. And we actually made the switch to Cytopoint for him as we were getting him started on his immunotherapy. His Chief is a service dog. And so though he was doing really well, there was a point that it was quite overwhelming for the owner to give a lot of medications at home. And so what was wonderful is Cytopoint controlled his allergic pruritus. As we had him on the immunotherapy in the appropriate diet, we got to the point where the Cytopoint frequency could be spread out to control his allergic pruritus because the immunotherapy ended up helping to desensitize him. So I have seen Chief now for, I think, 4 or 5 years. I'm happy to report he still follows up and comes to see me, and his degree of how often he breaks out has dramatically decreased. He still needs Cytopoints during certain times, but the frequency has been able to be less because of immunotherapy. So that's kind of a typical thing we're looking at with desensitization is we might still need those symptomatic treatments, and often we do, but can we lessen the pyoderma? Can we lessen the otitis? And can we lessen the frequency of some of these therapies to relieve their allergic pruritus? And so he's been doing very, very well for the last few years.
Yes, a dermatology success story. That's what we're here for. That's what I like to hear.
Absolutely.
So forgive me if I'm asking you to repeat yourself, but of the topics that you addressed above, what are the most important considerations that you'd like to make sure practitioners are addressing every time in these patients?
Yeah. I mean, we can say how often, however many times you want, if it'll help get it really clear. Cause this is what, again, I see all day, every day. Do not skip the ectoparasite control. I mean, we are so fortunate to have the isoxazolines. So when I started doing dermatology, at first we did not have those. Now we have them, and they're just such an easy way to have good, effective ectoparasite control, to get those easy wins. So definitely, I know it kind of depends on geographically where you are, but definitely utilizing something like isoxazoline therapy. And I can flip a question any which way to get cytology in there somewhere, because it is just that important. We do not want to give up on good symptomatic treatment because there's an infection. You guys, the cases I manage, I have an atopic dog. She gets infections. Like, it just happens even in well-managed allergic dogs. And so we want to address those, get them through those, and not give up on good symptomatic treatment like Apoquel or Cytopoint to manage their allergic pruritus, because there's an infection that we just have to address. That's going to happen for a lot of our cases. And so we are so adamant about cytology, and you can really teach yourself cytology, in a very quick manner. You can teach your technicians, your assistants to do it for you, to save time. There's just really a wide array of ways that we can implement cytology into our practice, which is why we are so passionate about talking about it.
All right. So it sounds like we really should be performing a cytology on every patient that we see. Is that correct?
Yeah. I mean, in an ideal world, it's non-invasive, lots of information quickly. So I would love to cytology everything. I do appreciate that we are all in different situations, depending on finances, depending on time, depending on comfort level. So I certainly can go over times that I think it's super important, but in my perfect world, we would cytology everything if we were able to.
Thinking about cytology, and I'm kind of bearing my soul here on camera once again about my weaknesses and shortcomings, but can you tell me a little bit more, when I'm doing this test, what types of organisms and things like that are we looking for on cytology?
Yeah. And you guys do a lot as general practitioners. So let me stop by saying, realize that I am just doing dermatology. So it is a lot you guys have to manage. So I think it's really easy, depending on your training, and if you had a dermatologist at your vet school, or depending on the practice you landed in, whether they do a lot of cytology. So a lot of people are uncomfortable with it. So, just solidarity in the fact that not everyone does feel comfortable with cytology, and that's okay. There's tons of resources out there where you can learn how to do cytology better. What I always say for people who want to start learning is, practice on animals that are sedated, or you're going to do general anesthesia for a dental or a spay. Like, practice on patients that are really still, that you can have a mentor come and help you. Don't say, I want to learn how to do cytology, and then like the crazy pogo stick French bulldog comes in that's two, and you're chasing them down trying to get comfortable with it. So definitely practicing. It's just like any other clinical skill. Practice is really going to be beneficial for that. Same goes with what you're looking under the microscope, getting back to your question. So sometimes people get intimidated because, as dermatologists, we'll say, oh, those are acantholytic keratinocytes. Oh, those are lymphoma cells. I think you can get through 90% of your cases if you feel comfortable identifying bacteria, cocci rods, yeast, weird, right? Because if it's bacteria, okay, well, maybe we're going to culture, maybe we're going to implement topical therapy. If it's yeast, if you're at least finding malassezia and not just throwing them on antibiotics because you're not doing cytology, that's a huge win for that animal and for antimicrobial stewardship. If it's weird, what do? We biopsy or refer to a dermatologist. So even if you don't know everything that's under the microscope, cytology is a guiding tool. You don't have to get all of your answers from it, but it's just like if you guys ran a CBC or a chemistry on a pet who wasn't doing well, you might still need to do other tests, but that's going to guide you to get to the appropriate tests. So if you just get comfortable with that, bacteria, yeast, weird, you're going to do really, really well implementing cytology.
I think even I can pull off bacteria, yeast, weird. I feel
right?
pretty good about bacteria, yeast, and then I can say I have no idea what else I'm looking at here.
I see things under the microscope that I'm like, I don't really know what that is. And what do? I biopsy it. So yeah, you're doing great.
Let's talk a little bit more about treating infections for the things that I can identify, bacteria and yeast. I know that that's not always straightforward. So what sorts of things do you consider when you're deciding between topical and systemic therapy for infections?
Well, do you have a 2 hour long podcast that we can talk about this on? Because
I wish, because I want to
right.
know it all.
It's tough, and there's a lot of information and a lot of things that we're still really learning. The one thing that I will kind of preface, because to really summarize all of pyoderma and topical versus systemic treatment is, I mean, that's a day lecture I could give. But we are really trying, especially for superficial pyoderma, to focus on topical therapy, to be good stewards of antimicrobials for one health. We do not just want to throw everything on a cephalosporin. That's why I'm so passionate about cytology, because again, I see cases that don't have any bacterial infection at all that have just been given lots of cephalosporins. So start by doing cytology, but really, even if you find a lot of cocci, if it's a superficial pyoderma, and we can, utilizing things like 3 to 4% chlorhexidine is what the literature shows us, can be really beneficial. And you might not even have to reach for an antibiotic in that case. And there's lots of different formulations between shampoos and mousses and wipes and sprays that we can utilize topical therapy. And every case is different as far as frequency and things like that. But really reaching for topical therapy when you can be helpful. Certain situations where maybe we can't do that and we do need to reach for systemic, it comes down to what the owner is able to do, what the pet will allow them to do. Maybe they can't bathe their 180-pound, dog every single day, or they're fearful of topical therapy. If we have a deep pyoderma, so like really thick draining tracts, purulent debris, then we're going to have to reach for systemic therapy. If you are reaching for systemic therapy, rechecks are important, because when we recheck them, including cytology, if they haven't responded, that's where we really have to consider culturing that animal. We don't want to do antibiotic roulette. We don't want to just do 5 or 6 antibiotics and have them not respond. We really, at that point, need to get aggressive as far as diagnosing the true pyoderma with a culture, so we can get those sensitivities if we are going to reach for systemic therapy.
All of the topical formulations that are available, I feel like more and more are available all the time. And I don't think that was necessarily the case when I first graduated. So very exciting to have all these different options that we can reach for. And then, yeah, my stomach turned a little bit when you were like 5 or 6 antibiotics. And I was like, oh gosh, because it happens. I know I've done it in cases and things. So yes, anything we can do to keep that antimicrobial stewardship in mind and keep everybody healthy sounds like a good plan to me.
Yeah, absolutely. It's super important, and one of the most difficult things we deal with in dermatology.
So moving to a different type of presentation, how about Lincoln, who's a 9-year-old male-neutered English bulldog? Lincoln has a history of allergic skin disease that has typically been responsive to supportive care, but not only is he now only marginally responsive to treatment, he's also exhibiting other changes. So what sort of diagnostic approach would you take with this guy?
Yeah, whenever you have different lesions, again, that's where we have to take a step back, because we see lots of dogs that have allergic dermatitis, but that does not mean they can't develop other diseases. Whether it is that they're having a resistant pyoderma or they've just developed something completely different. And that's where, again, cytology is so important, because if I have a dog coming in and they're crusty and kind of showing different lesions than they ever showed me before, then I'm going to look under the microscope, because maybe we've developed an infection that we need to get a handle on, or maybe one of those weird things comes underneath the microscope. And it was one of those weird things, that's what we're going to consider biopsying. But we also don't want to biopsy super infected skin. So that's why that's extremely important that we start with our minimum database, which is cytology. So I'm going to start with that. And in this particular case, if I saw a lot of bacteria that was non-responsive, I'm going to culture it and probably do topical therapy while we're waiting for those culture results. Or in Lincoln's case, because again, this is a case I truly have seen, Lincoln was a case that I managed allergic dermatitis in and successfully for a couple of years. And then all of a sudden started not responding to therapy and got lesions that were very weird. And so what we saw under the microscope for cytology are cells that were really weird. So these cells are called acantholytic keratinocytes, and they're often indicative of pemphigus foliaceus. You can see that they're a bit rounder and bigger than a typical keratinocyte and very basophilic. And these are just skin cells that have prematurely lifted based on the disease process. And so this particular case, we did end up biopsying, and we got a pretty interesting diagnosis. And that was Lincoln was a poor dog that developed pemphigus foliaceus. So had a history of allergic dermatitis, atopic dermatitis for a couple years, and then developed pemphigus foliaceus, which we can see in some of these cases.
Poor Lincoln.
I know.
So kind of like cytology, biopsy is not something that I commonly do in practice. So I'm always a little bit nervous about taking that sample, spending that owner's money, and am I going to get a diagnostic result with that biopsy? Can we, just like the cytology, can we talk about tips and tricks for those of us that don't have a huge comfort level with this and helping us get a good diagnostic sample? For example, I have been told in the past that, don't just take your sample and send it off like you would a mass you removed or something, that we should really be seeking out a dermatohistopathologist. Is that accurate?
Yeah, that would be one of my top tips. Absolutely. The skin is a very interesting organ, right? It's a huge organ. There's lots of things that our skin gets exposed to. There's lots of things our skin can do. And there are some strange autoimmune cases that you really want someone trained in dermatopathology to evaluate. So I completely agree. And there's a lot of really wonderful dermatopathologists out there. So find a dermatopathologist that, you can send pictures to, that you can send your samples to, that you can give a good history to, and that they're open to also kind of chat if you do get a result back that you feel like it's a little bit weird, because sometimes we do have to actually follow up with our dermatopathologist. The couple other things that come to mind when we talk about biopsying, I like to say go big or go home. So, we don't want to be wimpy with our biopsies, especially if it's like a diffuse case on the trunk where we have a lot of skin. We don't want to be taking 2 mm punches of those areas. So I usually am taking 6 mm punches. So it's not like you have to go super crazy with a 12, but I'm usually taking 6, maybe 8, because I want more information for my dermatopathologist. I want to, put the odds in their favor that they're going to really identify what we need to identify. The other thing I think is really important, well, I actually have 2 more for you. Do not sterilely prep the biopsy. I know that goes against everything we think of when we're cutting into the skin, especially if it's crusty. But sometimes the answer is in the crust, and you can actually wipe away the answer. So unless you're doing a tissue culture, we usually do not prep our biopsy samples at all. And if a crust falls off, I pick it up and I put it in the formalin jar, because the crust, the scale, all of that stuff often can have the answer of what our dermatopathologists are looking for. The other last thing I want to give as a tip, multiple sites. So if you have diffuse disease and you're not just taking off like one nodule, don't just send in one site. I'm sending in like 4, 5 sites, because sometimes just 1 or 2 of those will really be representative of the disease. And again, we want to maximize the chance that our dermatopathologist can actually identify what we want them to identify. So multiple sites, try to get bigger biopsy samples if you can, do not sterilely prep, and then find a dermatopathologist that you enjoy working with and send your samples to them. Or if you don't feel comfortable, go ahead and refer to a clinical dermatologist.
Once I get this biopsy sample, can I just take that sample and put it straight into my formalin? I feel like I read something at one point about like having it on a tongue depressor or something like that. Can that just go straight into formalin?
It depends on how bloody it is. So I don't put it on a tongue depressor. I'll put it straight into formalin, especially if it's a diffuse one where we're putting all of them in the same jar. If you have different lesions or trying to separate them, you might want to put them in separate jars, but you don't want it to be super bloody. So a lot of times if it's like, a lot of hemorrhage on the sample, I'll very lightly and you don't want to damage the sample. So you don't want to take your forceps and really crush it either, but very lightly kind of blot it to get some of the extra hemorrhage off. And then I'll put it straight into the formalin jar.
Well, Dr. Bourgeois, this has been awesome. I know that I've learned a whole lot, and I hope everybody watching has too. Thank you so much for joining me today.
Oh, thank you so much for having me, Cassie. I mean, this has been wonderful. I really appreciate you guys spending some time going into dermatology. And again, I really, really think general practitioners can practice wonderful dermatology. You just got to get comfortable with a few of these basic steps, and then you can learn to have fun with it.
I love it. I love it. I look forward to taking some of these tips that you've given us here and implementing them for the benefit of my patients.
Yes, I hope so. Something that you can implement right away is always my goal when I'm teaching dermatology.
I think you have checked that box in multiple areas during this video.
Awesome. Thank you so much.
And thank you to Zoetis for sponsoring this edition of Vet2Vet. Check out the Spark section of vetfolio.com for more of our V2V discussions on various topics in veterinary medicine. And remember, if one animal is better off because of you today, it's a great day. Here's the important safety information for Apoquel, oclocetinib tablet. Do not use Apoquel in dogs less than 12 months of age or those with serious infections. Apoquel may increase the chances of developing serious infections and may cause existing parasitic skin infestations or pre-existing cancers to get worse. Consider the risks and benefits of treatment in dogs with a history of recurrence of these conditions. New neoplastic conditions, benign and malignant, were observed in clinical studies and post-approval. Apoquel has not been tested in dogs receiving some medications, including some commonly used to treat skin conditions, such as corticosteroids and cyclosporins. Do not use in breeding, pregnant, or lactating dogs. Most common side effects are vomiting and diarrhea. Apoquel has been used safely with many common medications, including parasiticides, antibiotics, and vaccines. For more information, please see the full prescribing information at apoquel.com/PI. Apoquel indications: control of pruritus, itching associated with allergic dermatitis, and control of atopic dermatitis in dogs at least 12 months of age. Cytopoint indications: Cytopoint has been shown to be effective for the treatment of dogs against allergic dermatitis and atopic dermatitis.